morning. It's Dr. Christopher Martin, and welcome to Medical Grand Rounds on May 20th, 2022. Today for Medical Grand Rounds, we're very excited to have two of my colleagues from RVH, Dr. Russ Price and Heather McMahon, to talk about blood transfusions and more specifically, a new initiative called Using Blood Wisely. So thank you so much, Russ and Heather, for coming. I really appreciate your time. Russ, I'm going to start with you. Tell me a little bit about yourself, your role at the hospital.
Well, thanks for inviting me, Chris. I really appreciate the opportunity to talk to you today about this important program. For those of you that I haven't met, my name is Russell Price. I'm a physician specialist in laboratory medicine, and I've been the medical director of the laboratory here at RVH for 25 years. I trained in Kingston at Queen's University and got my fellowship in general pathology there, and after a short time working in Kingston, came to Barrie.
Wonderful. Thanks so much, Russ. And Heather.
Okay, I'm a medical lab technologist. I'm in charge of the transfusion services here at RVH. I started my career going to school at the Toronto Institute of Medical Technology, which is now actually called Michener Institute of Technology. So that was 42 years ago. It's a long time ago. I did my training at Etobicoke General Hospital in Toronto, where I worked actually for 8 years. I took a little bit of a hiatus when my son was born, and then I started at York Finch Hospital, which became Humber River Regional Hospital. So I stayed there for 21 years, and fortunately, I got a position up here, RVH 10 years ago, as the charge technologist. So I didn't have to travel to Toronto anymore. So it's been nice to be here, and I've learned a lot in this role here.
Wonderful. Thanks so much, Heather. I mean, between the two of you, tons of experience and the right people to be leading this initiative and talking to us today. So tell me, what is Using Blood Wisely?
So the Using Blood Wisely program is the first national campaign of the Choosing Wisely program at Choosing Wisely Canada. So I think many people will be familiar with Choosing Wisely. Its mandate is to reduce overused and unnecessary tests and treatments in patients, and thereby to reduce risk of harm to those patients. The Using Blood Wisely program is under the umbrella of Choosing Wisely Canada. It's sponsored nationally by the Canadian Blood Service, and is also promoted by Accreditation Canada. And its objective is to ensure safe transfusion of blood products, judicious use of the blood supply because it's not limitless, and it uses a system of auditing transfusion practice, establishing a baseline, introducing some educational initiatives, and then re-auditing the transfusion practice to see if there's improvement.
Perfect. Obviously Choosing Wisely Canada program has been very successful in decreasing, as you said, potentially unnecessary tests and treatments. So this is a natural progression of such an important resource. Now, so why else is this initiative important?
We can think of it in three ways. The first being risk. So like virtually all medical and surgical treatments, there is some risk that is attached to any of those treatments, and it's important for all of us to be mindful that prescribing any treatment to a patient is going to be beneficial to them and will outweigh those potential risks. So blood transfusion is not a risk-free procedure, and it's important to be mindful of that in order to reduce the risk of unnecessary harm to patients. The second important point is the supply chain, and so we're all well aware of supply chain issues in all kinds of things in the hospital. The blood supply is obviously a precious and finite resource, And so we want to discourage any unnecessary use of blood products, unnecessary transfusion, because that's wasteful. But furthermore, it risks the supply of blood products to patients who really need that as potentially life-sustaining procedure. And then the last that we can think about is the cost. Hospitals are not charged directly for blood units. We're unlike the system in the US where hospitals are charged and there's a line item on their budget for transfusion products. In Canada, the cost of this is borne by the Canadian Blood Services nationally. But ultimately, of course, all of us as taxpayers fund all government operations. So at the end of the day, each of us as taxpayers is funding the cost of transfusion. And it's not small when you take into account all of the things that need to go into preparing blood for transfusion. It's been estimated that the cost is anywhere between $500 and $1,000 per unit transfused.
Yeah, not a cheap endeavor and cheap treatment. And we've always, as you said, we've seen in times when there's blood shortages, and it's a scary time if you have a blood type that's in short supply. Now, this initiative, what care areas does it apply to? Is this for emerge, ICU, the ward, or the OR? Where should this be kind of applied to?
Well, that's a really good question because it might introduce potentially some misunderstanding or anxieties related to this program. So the research that was done behind the Using Blood Wisely program supported the use of auditing transfusions primarily in stable, non-actively bleeding inpatients. We can extend that to patients in the operating room as long as we're not talking about emergency situations with massive transfusion and those sorts of things. And then also some of the emergency room patients would qualify for this program of auditing, particularly those patients that are stable, but they're due to be admitted to the hospital and need to be transfused potentially in the emergency room before they're admitted to hospital. It's obviously not an effective program in situations of very severe emergencies such as massive hemorrhage. But you'll know, Chris, and many others will be aware that we have a massive hemorrhage protocol here at RVH that was very carefully developed, and it's separate and distinct from this Using Blood Wisely and takes care of those situations particularly. The program is also not extended to outpatient transfusion. So as an example, our acute leukemia patients that are post-bone marrow transplant are receiving regular transfusions of red cells and platelets in order to sustain those counts as a recovery from that bone marrow transplantation. And so the auditing of pre-transfusion hemoglobins and single-use transfusions and so on wouldn't really apply very well in that situation. For the same reason, we've also included renal dialysis patients from this program. So in summary, we're talking about auditing transfusion practice mainly in stable inpatients, most OR patients, and some patients admitted through the emergency room.
And I just wanted,
sorry.
I just wanted to add that some of the reason they don't want to include emerge patients as well as, like Dr. Price said, sometimes they're a lot of emergencies are used as a clinic. So the doctor sends them in, they're transfused a few units, and then they go home. So we don't want to include those at all.
Yeah, I agree. They're more of an outpatient person, a convenient outpatient visit.
Yeah.
So really, it is kind of stable inpatients with anemia or low hemoglobin levels, and not applying to that, as you said, Dr. Price, the massive transfusion, these very unstable, actively bleeding to the point of hemodynamic instability, but still a large population of patients who this will really make an impact for. That's a large group. Those stable inpatients probably, consume a majority of the transfusion. So again, there's a big target audience. Now, is this initiative just for physicians, or does it apply to other, allied health and RNs?
Right. So it really applies as guidelines of practice for everybody that's involved in blood transfusion. So physicians, of course, are the ones that initiate the order to transfuse, and so it's incredibly important for our physicians to understand the two benchmarks that we're auditing against, that being a pre-transfusion hemoglobin trigger and the practice of single unit transfusions. But our nurses also need to be very aware of this so that they can assist in situations where perhaps there's some physicians that maybe are not quite so familiar with blood transfusion, don't prescribe transfusions very often, and they might need a little bit of assistance with the appropriateness for the transfusion and the guidelines. And of course, nurses are our staff that monitor bedside transfusion. So it's vitally important for our nurses to be involved in best practice transfusion at all levels. Our laboratory medical technologists are obviously the ones that prepare the units for transfusion before they're issued, and as part of this program, they will be empowered to screen all transfusion orders, look to see that these fit within established guidelines, and if there's some questions related to that, they will have the ability to contact the physician and ask for clarification.
So to add to what Dr. Price is, there is an actual algorithm that's set out by the Ontario Blood Coordinating Network, Ontario Regional Blood Coordinating Network, and it's very good tool for technologists to go by and have the discussion with either the physician or the nursing as well.
Absolutely. Now, and with this review by the technologist, is this 24/7 Monday or 7 days a week, or is it mostly going to be daytime hours? How is that going to work in terms of if I order transfusion and it's maybe not appropriate? Is there a time limit or is there a time where I may not or may get a call?
I think to start with, because we haven't really rolled this out yet, a lot of hospitals, what they do is they start with a Monday to Friday, 9 to 5 type of scenario, just so we get used to it, the physicians get used to it, that kind of thing. But eventually it should roll out to 24/7 a day, or 24/7, I'm sorry. And but again, we don't want to deny the product for a patient. So if discussion goes that potentially the doctor really does feel that they need the two, we can follow up with the physician after. So we will not deny the product for the patient.
Got it. And then that makes sense, because I would assume a lot of these transfusions are going to happen during the day because, again, they're not unstable patients. So, that coverage seems appropriate. And I think even the conversation is important that, and I always find it valuable to talk to the lab techs. I mean, look at the action behind you, Heather. I mean, there's such a crew and a cast, part of the team behind the scenes that the clinicians and the nurses don't see. And I think this is great that it applies to the whole team, because we are a team. Like, there's no
absolutely,
there's no one person that's involved in this whole process of blood transfusion reaching a patient. So that's wonderful. Okay. Now, you talked Russ earlier about the risks associated with transfusion, and then that's a big issue that we need to be serious about. That blood transfusion have serious side effects. So what are some of the common ones we see, and how common are they?
So, this is really one of the kind of foundational initiatives that's part of this Using Blood Wisely program. As you mentioned, there are common transfusion risks that we're all very familiar with, things like fever and allergic reactions, skin rashes, hives, that sort of thing. Those happen in about 1% of transfusion episodes, and they generally are minor reactions. They're easily managed with either some Tylenol or some antihistamines. And in a way, we can almost be lulled into a little bit of a sense of complacency because, they're fairly minor reactions and they're easily managed. At the other end of the spectrum, there are obviously serious and potentially lethal transfusion reactions, and the one that comes to mind are the acute hemolytic reactions. These are always related to ABO mismatch and invariably relate to misidentification of the patient. So what we term as the wrong blood in the tube, and so the blood that we're testing in the tube doesn't match the patient who gets the transfusion product. And if there's an ABO mismatch, there is a risk for very serious hemolytic transfusion reaction. These happen about 1 in 40,000 transfusions, so very uncommon. Another one that we often think about when we think about transfusion reactions, and because of the kind of the published literature that occurred during the late 80s and early 90s, these are transfusion-transmitted viral infections, things like hepatitis C and hepatitis B and HIV. Thankfully, with modern testing technologies and using PCR techniques, these are vanishingly rare, less than 1 in a million transfusions that any of those infectious complications occur. There are some important ones that may not be so obvious and are fairly common. One that comes to mind is transfusion-associated circulatory overload. And so the situation that occurs here is a transfusion of a couple of units of red cells to a patient with kind of borderline heart status, and causes an overload situation and precipitates pulmonary edema. And we may not link the two, the red cell transfusion with the pulmonary edema, and recognize this is a complication of transfusion. And these are fairly common. It's been estimated that 1 to 5% of adults in the ICU will develop some circulatory overload. And it may be even more common than that because we're just not recognizing these. The second one that comes to mind that's an important reaction that we might not think about at the time of transfusion is the development of red cell antibodies. And so this is also fairly common, can occur in up to 10% of transfusions, and is most important in young women because those antibodies that are acquired from the transfusion may complicate future pregnancies, and we obviously want to avoid that situation. So there's a range of things that are common and not so worrisome, common and maybe potentially clinically serious, and then some really rare ones.
Yeah, and one that I don't know if you mentioned, Dr. Price, was the transfusion-related acute lung injury, TRALI. That can be a potentially life-threatening reaction as well. I think that's not always recognized by physicians or nurses because it isn't that common. And it is less common now since the introduction of mainly male donors for plasma, and which was introduced a number of years ago.
Yeah, that's a really good one, Heather. And both TACO and TRALI, so the circulation overload, we see that in the ICU. And TRALI, again, it's a little more, you have to think more about that one because it's not quite as temporally associated with the transfusion as TACO is, but both are very serious. And, there's definitely a morbidity associated with ending up on a ventilator for either one of those reasons. So as you said, there's lots of, although there are a lot of the serious ones are luckily uncommon, with the number of blood transfusions we do see them. So there, again, giving blood is not a benign process by any stretch of the imagination. Okay, and now when we get back to the initiative itself, and when we look at improving, what kind of national benchmarks are we actually measuring ourselves against in this program?
The Using Blood Wisely program has two benchmarks. The first of these is a restrictive transfusion trigger. And so the benchmark here is to not transfuse unless the patient's pre-transfusion hemoglobin is less than 80 grams per liter. There's lots of good published evidence to suggest that transfusion at hemoglobins higher than 80 grams or even higher than 70 grams is probably not helpful in most situations. Obviously, there are some patients where transfusion at higher hemoglobin triggers may be relevant, but for the most part, that's the guideline. There's great published trials in the literature. The TRIC trial is kind of the granddaddy of these. This is transfusion in critical care. The FOCUS trial is one that looked at functional outcome of cardiac patients who've undergone hip surgery, and the TRICS-3 trial is transfusion in cardiac surgery. So all of these studies demonstrated that using a restrictive transfusion threshold versus a liberal transfusion threshold was non-inferior. So in other words, there was no additional patient harm that resulted because the patient was transfused at a lower hemoglobin threshold. It's also important to remember that these are not young, healthy patients. The average age of the patients in these trials was in the 70s and 80s, and they had major cardiac comorbidities, and so the evidence is really strong in favor of using a restrictive transfusion threshold. So the benchmark then that we use in the Using Blood Wisely audits is to ensure that at least 80% and hopefully more than 80% of transfusion episodes are given to patients with hemoglobins less than 80. So there's a little bit of flexibility, and then there's 20% that will allow for unusual situations where the patient might need to be transfused and the hemoglobin is actually over 80. The second one relates to single unit transfusions, and in the original design of this Using Blood Wisely campaign, the idea was that a single unit of red cells was given on any given day. I think they realized when this went into practice that it's not uncommon for patients to receive more than a single unit of red cells in any given day. And so they revised the definition there as a transfusion of a single unit in a situation where the hemoglobin is less than 80, stopping after that single unit, doing a clinical reassessment, seeing whether or not the patient's symptoms have been relieved, measuring the hemoglobin again to see if we're above 80, and then making a decision to proceed with the second unit of transfusion. And the benchmark there for Using Blood Wisely is 65%. So we want to ensure that 65% of all transfusions are given as this single unit strategy. Again, there's some flexibility to allow for situations where it might make sense to just to prescribe more than a single unit at any given time. We're doing really well. Our physicians are, with respect to the hemoglobin threshold, our physicians are transfusing to our patients more than 90% of the time at hemoglobins of less than 80. So, congratulations to all of those physicians. I think everybody's really mindful of the hemoglobin triggers. The single unit transfusion is a bit of maybe a new way of thinking of things. We're not doing quite so well on that. We've got some room for improvement. I think we're in the 55% range, Heather, based on the audits that Heather has done. And we want to get to that benchmark of 65%. So those are the two benchmarks: the hemoglobin trigger of less than 80 grams and prescribing 1 unit of blood transfusion at a time.
So how we so Heather, are you doing audits on that? How is that those numbers being tracked?
Okay, so I actually haven't done any this year. I did 4 consecutive months last year. And like Dr. Price said, we're doing very, very well with our over like 80% for under 80 hemoglobin. But the 1 units were like 54, 55%.
Mm-hmm.
So there is an audit tool that's provided by using Blood Wisely. Um, I pull a transfusion report. It's actually a very manual and tedious process, to be honest. It would be nice to be automated, but sometimes it's not as simple as that. So yeah, I pull a transfusion report, track about 50 consecutive transfusions. I may go over, just like I try to end on a calendar day. And then I have a template, input this in, there's a calculation that's done. And then yeah, I get the answer at the end. So we are tracking these um, over time. We would like to see an increase, of course, in the 1 unit transfusions. We are doing very, very well with the under 80 for the 80% of transfusions. So I think we're well on our way with the interventions. These rounds, probably getting the information out to all physicians. Dr. Price going to MAC and doing the PowerPoint presentation. And then I guess with the audit, the algorithm screening by technologists, I think will be very helpful. But yeah, it took me a while to actually get the hang of doing the audits. I guess with Expanse and the pandemic, a lot of these things have been kind of put on the back burner. So we're looking forward to moving on to the next step and increasing and getting the designation, I should say. So
What's
after
that?
you have, so using Blood Wisely designation, so if you maintain or meet the benchmarks for 4 consecutive months, you can apply for a using Blood Wisely designation. If you've improved even 20%, you can get a recognition, and this can be used towards Accreditation Canada. Yeah, so but then you have to also maintain that. So I do submit this into CBS website, the Using Blood Wisely, and it's forwarded to obviously the powers that be, and they do track us as well. So I think a good part of the country is now becoming using blood designated hospitals, and so we're hoping to move into that designation.
Absolutely. Well, I think that we're on the right track already. Now, you talked about the data is important and it is challenging
Yes.
sometimes. In the future, do you see the data being available by department, for instance? So, like the surgery department versus medicine department to help focus improvement efforts? Do you think that's a possibility in the future with the data if it becomes more streamlined or et cetera?
Yes, I think we can go that way. I know even hospitals have narrowed down to actually physician practice as well. When I do the audits, I do track the actual units where or the wards where the units are transfused. But like I said, we could probably even narrow that down to physicians as well. But yes,
Yeah.
I think that's something that we could potentially do in the future.
Yeah, that would be. I think all physicians like objective, feedback on their practice. So even anonymous kind of stuff by department would help. Now you talked about some other, strategies we're, starting to use to kind of implement this program. Obviously this rounds. Dr. Price came to MAC. Are there any other resources or strategies that are going to help improve our performance and get us above that threshold?
There are, and I think as Heather mentioned, the timing has not been great in the last couple of years for obvious reasons. Not only the pandemic, but also the upgrade of the Meditech system. I think guys were focused on much more important things at the time. So the timing now, I think, is good, and so we've begun some initiatives that you've mentioned and Heather mentioned. I did speak to the MAC last month to give a presentation on the Using Blood Wisely program. And it's my hope that the physician chiefs will take that information back to their monthly department meetings and start to kind of socialize this program. Heather and I are available to be invited to speak at those meetings if the chiefs find that to be helpful. This Grand Rounds is really a great opportunity, and I want to thank you, Chris, for inviting us today. It's a really good way to get the message out to everyone across the hospital that's involved in transfusion, no matter what their role is. There's a number of resources that are available on the Using Blood Wisely website. There's some really good short educational videos that are targeted to physicians, to nurses, to lab staff. And so we're going to look into making easily available links on our own computer system to those videos so that people can watch those. They're I don't know, maybe 10, 15 minutes, that sort of thing. But it's a really good source of information that that describes this program. There's some best practice reference materials and some sample order sets that we've looked at, Heather and I. And then there's some screensavers, which after we kind of socialize this idea and get people aware of the program, we're going to start to ask our IT friends to put up some screensavers for us that will advertise the Using Blood Wisely strategy. And then lastly, I'd like to just mention the Ontario Regional Blood Coordinating Network. Heather mentioned them a moment ago. They're an Ontario organization that's focused on transfusion practice. They've got a really rich resource of online educational resources on their website. And one of those is called the Bloody Easy Light program. There's a version for nurses and a version for physicians. These are a little bit longer video programs. They talk about the breadth of transfusion practice, as well as recognizing and responding to transfusion reactions. And there's educational credits that are available, Royal College or College of Family Practice credits that are available by taking those programs. And so we'd like to put some links up so that physicians can access those too.
Absolutely, though. The Bloody Easy program every physician should do. I think they're just a really well done program. They've been doing them for years. I remember doing them as a resident. Just a long time ago now. Right. That's great. And we'll include some of those resources on the link to this, the Grand Rounds, so people can access those as well. Tell me about the evidence behind all this stuff. Tell me about the START study, because that's going to come up a little bit. What is the START study?
So that's a study that we can all be proud of as Canadian physicians and medical practitioners. It's a Canadian study that was published in Transfusion in 2021. Transfusion is the journal of the American Association of Blood Banks, and so it's an internationally recognized journal for transfusion practice. START is an acronym for screening by technologists and auditing to reduce transfusion. In this study, there were 13 participating Canadian hospitals, and those hospitals agreed to a standardized set of red cell transfusion guidelines, including transfusion triggers, used a number of educational tools, some of which I spoke about a moment ago, to get the message out to everyone involved in transfusion, used prospective screening of transfusion orders by our technologists in the blood bank that we also spoke about. And then there were monthly meetings that looked at each transfusion episode and kind of assessed the appropriateness of that transfusion. The study then was able to very clearly prove the effectiveness of the guidelines for transfusions, the effectiveness of educational programs, the importance of auditing, and they demonstrated that there was a significant reduction in the total number of red cells that were transfused at each of the hospitals. There was a reduced median pre-transfusion hemoglobin, so that transfusion trigger hemoglobin trigger before transfusion was moved progressively lower. There was an increased rate of single unit transfusion, something that we want to promote. An increase in what was judged as appropriate transfusions. And then importantly, there was no adverse impact as a result of any of these initiatives. So there was no impact on the length of stay or need for ICU support or increased patient mortality. So a great study that really supports the principles of the Using Blood Wisely program.
Wonderful. So evidence to support a good initiative, which people want to see. They want to see the data that supports these programs and the decisions they're making. They want to know that if they do adopt a more restrictive transfusion strategy, that they have evidence to support the care of their patients, which there is. And there's good evidence, as you brought out during this talk. My last question is going to be one that, I get asked all the time by my friends and family. How's our blood supply? Are we going to run out? Are there any situations where we could run out, like we run out of N95s or, COVID tests?
Well, yeah, unfortunately, we have a very good donor pool for Canadian Blood Services. They're very dedicated. But yes, it is a scary thought. We do have situations where we do go into, they call them phases, where we have red phase, which is 25%, orange or amber phase, which is like 50%, and then right now we are on green phase. So even though there's a good supply in Canada right now, and we do have to report our red cell inventory every single day to Canadian Blood Services, they do look at the inventory in each hospital. So they come up with this green phase. And that could go on for a little while. There was a memo that went out just recently. I think you might have received it. And they're just, with the pandemic right now and so many COVID cases, of course you have to have healthy donors. So this has impacted the blood supply right now with O negatives and B negatives. But over the pandemic, actually, we've been very, very fortunate to not have had any advisories, which is great. And so they just, this is another good reason to implement this initiative, so that we, reduce our number of transfusions to help with the blood supply. Because of course, we want it there for patients who actually really need it in urgent situations. So it can become a very scary situation. I've dealt with some platelet situations, and that's, it's unnerving for a lot of physicians because, their patient's bleeding, the platelet count's under 10. But then again, they do actually need to look at, is the patient actually bleeding? Maybe their count is low. It's like with red cells, is their count really, it's low, but are they stable? That kind of thing. So, yeah, we do have to be very cognizant of the blood supply, and been very fortunate. I guess with the reduction of surgeries as well, that's kind of helped. Not in a good way for patients, I suppose, but for our blood supply, it has definitely been kind of helpful.
Absolutely. I mean, as summer comes up, we call it trauma season. So,
yes.
So that's when we need the most blood. Okay, so the big take home points here: using blood wisely in stable inpatients. Carefully consider transfusions, using the guidelines available, using the evidence, and using this program's initiatives on restrictive transfusion. For more information, you can go to usingbloodwisely.ca and other references that are found on the education website. Russ, Heather, I want to thank you both so much for joining Medical Grand Rounds this month. This is a wonderful program, and you guys are wonderful, passionate advocates for responsible and evidence-based blood transfusion. And thank you so much for everything you do here at the hospital.
Oh, you're welcome. Thanks for having us.